about Partners Health in Rushcliffe, and I won't steal any thunder, so I'll just introduce you to Dr. Stephen Short and Dr. Matt Jack.
Wow, thank you very much. First of all, in telling the story of Partners Health and Principia, I think it's essential to, first of all, make it clear that context is everything. And so when I say that, this is our organisational response to the challenges and pressures that we perceive in Rushcliffe, as visualised through our own eyes, and which we have problem solved around together. And so it is very much our sense of how we ought to face the future challenges and current pressures. It's not to disrespect anybody else's view of their organisational response in the context of their system and their configuration and needs. And so we say that humbly. But necessarily, the thought processes and development phase that we've been through is necessarily of relevance to you, I believe. And I think many of the things that we've considered and many of the responses which we've considered are complete relevance to perhaps your own experiences as well. So Partners Health is our collectivised model general practice, and I'm going to set out some of the context of why Partners Health. Matt is going to tell you some of the practical features of how we've done Partners Health. And Partners Health has a relationship with Principia, which is our MCP, our new care models, and again that will come out in conversation and question as well, I think. So Principia is, this is the least snappy strapline of any you've ever come across, but it's more, it is a description, an explicit description of the task we set ourselves. So Principia is a journey from multiple unconnected practices to an accountable, community-based, integrated services at scale, and I hope we'll demonstrate that as we go through. That's you. The origins of Partners Health and Principia derive directly from the current pressures and the future challenges of our system, some of which you have discussed this morning. But I want to perhaps just illustrate them briefly. And on this I'll draw some of our experience from the CCG, because both Matt and I have roles within the CCG, leadership roles in the CCG also, and clearly the context of the CCG finances and the system service pressures are clearly highly relevant. So what we know, and I think David Pearson this morning will have emphasised this, is that there are profound systemic financial challenges stretching out before us, and financial deficits in an unreformed system in Greater Nottingham, for example, stretching to hundreds of millions of pounds over the next 5-year period. There are also at the same time profound performance pressures. Those of us who operate within Greater Nottingham will regularly get notification, generally from Hugh, that ED is on black alert, and please be even more judicious users of secondary care, emergency care resources. We know that our emergency system is overcooked, our EMAS service is really struggling. We know that cancer performance is not as good as it should be. We know that service pressures in general practice are enormous. So these aren't going to go away, because the funding gap which exists both in health and social care, principally social care also, is something which is going to be at least a permanent fixture of the rest of life, professional life. And although grey hair gives away how much time I might have left, it's still a best part of a decade. So that's it's potentially a miserable existence. And so the final dimension that motivated us to change and to action was the fact that the workforce issues in general practice are becoming more acute. Now, we're fortunate to operate in Rushcliffe. It's an extraordinarily positive place to practice medicine in general practice. We have fantastic relationships with the activated population. We don't have many of the issues of deprivation that other colleagues face around Greater Nottingham, and it is a phenomenal place to be a GP. And we feel blessed to be GPs in Rushcliffe. And yet, most of our practices now, which are well set up, well established, mature practices, are even now having recruitment issues. Retention of doctors is becoming more difficult, and recruitment issues are emerging even in Rushcliffe. So we wanted to acknowledge these facts and rather become victims to this culture and these facts. We wanted to be the architects of a new future, a new set of potential arrangements which might help mitigate some of these pressures. And this is something which I picked out from Roy Lilly's blog from just yesterday, and I don't know whether you get Roy Lilly's daily blog. If you don't, you should sign up to it. It's a hoot. And he's a polemicist and a contrarian and a politician and a commentator, and he's highly opinionated, but he's fantastic. He's nearly always right, and actually it does lift the spirits sometimes when you hear him having a good rant. But the important thing, even from yesterday's blog from Roy Lilly, I'll read it out, and again, it's difficult. That's how he gets his reputation, but it's nevertheless not true because of it. He talks about the STPs, which we've been talking about this morning, and he talks about the presidential system, and he talks about, is there a way through all this? Maybe. And he goes on to say, for a start, it means forgetting about your organisation, your practice, your CCG, your hospital. The days of standalone constituent parts of the NHS are over. Each part wants a discrete unit, management and board, turning in on a set of accounts that balances regardless of the havoc that might wreak elsewhere. The NHS has to move from constituent service to a competent service, each component playing its part in the success of the neighbouring components and as a result for everyone. And so that for us was a really clear encapsulation of why we've done Partners Health and why we are doing Principia. Because we came to the view that as Goanli talked about in the BBC Reef lectures a few years ago, we're living in the eccentric system in which neither individuals nor organisations on their own can solve problems. So we felt, even though we operate in a fantastic part of Greater Nottinghamshire, we operate within really mature, competent practices, we felt that our future was better together and that we would be stronger together. And I just wanted to kind of preface some of what Matt says about how we achieved what we've achieved by just telling you what we think we have achieved now. This is not a self-aggrandizing of things that we've done, but things that we have achieved necessarily, factually what we've achieved in the context of becoming Partners Health, which has given us a sense of satisfaction, deep professional satisfaction, some sense that actually we can make the hospital system better than it currently is to mitigate the costs that currently are spent in secondary care, and we can manage the financial and service risk going forward better together through this model. So just whizzing through some of these achievements. So we believe Partners Health have a unique model of collectivised general practice. It's a partnership of partnerships. It's a limited liability partnership. We're constantly reviewing its organisation structure and its status of purpose, but at the moment it's a partnership of partnerships. It's a structure which we understand. We're trying to reproduce across practices the sense of partnership which exists within practices. We're not all doing the same, but we do know that actually in each of our rooms in general practice, that although we may not all see the same patients and not operate in the same way, we are nevertheless motivated to the same organisational outcomes and with the same organisational culture and objectives and quality imperative. We've improved access to general practice with 100% access to online services, and now more than 32,000 of our residents are regularly accessing online services and using online services. Because of the way we've organised ourselves, we've created the incentive, the CCP, to invest in us as a collective rights organisation, and we've harmonised the pounds per patient across general practice and Rushcliffe. It used to be that my practice got £83 per patient, and Matt's you were on about 67. Matt's practice provided as good, if not better care than any practice in Rushcliffe, and yet he was systematically, year on year, funded at £16 less than my own practice. So now we've harmonised all practices at £90 per patient. And there's an additional £5 per patient incentive for the achievement of greater budgetary accountability. We've incentivised practices to hold a virtual budget in prescribing and first outpatient activity. And we're currently doing very well against both those responsibilities, and that's enabled us to access up to £5 per patient on delivery across the network, not at individual practice level, but across the network of practice. So we've achieved a very significant investment in general practice. We've achieved a standardised, codified approach to long-term condition management. We've built population disease registers. We're very fortunate, actually, all bar one of our practices on System 1. And because of the common work groups that we can set up in System 1, we've actually now effectively got a common disease registry for long-term conditions. And we codified care, we systematized care, we can now build registries and use care registries as well for planning and quality improvement purposes and reporting purposes. We've achieved an enhanced care home service which has reduced the number of ambulances being dispatched to care homes, numbers of patients being conveyed from care homes to hospital, numbers of patients being admitted from care homes to the healthcare elderly wards in NUH, and critically, more people now die in their place of preference. And critically, this has reached a level of statistical significance and will be published in a peer-reviewed journal in the months to come. So again, care homes, it used to be a dismal experience to be a GP to go to care homes. It now is a professionally enhancing and professionally satisfying thing to do. Proactive care, working in teams with community nurses, pharmacists, care home managers and age concern, along with the patients, representatives or carers. We've profoundly changed the nature of the offer to patients in care homes. And finally, just a few more on the next slide here before I hand over to Matt. Again, the future around Partners Health and Principia is that we're looking to be a population health organisation. And based around an initiative led by our colleague Neil Fraser, we are confident that we have saved 20 strokes in 2016 and we're targeting 50 more in 2017. We're now systematically screening every patient over 60 for the atrial fibrillation. We found hundreds of patients who didn't know they had atrial fibrillation, applying evidence-based medicine to those patients, and applying numbers to treat. We're very confident that we've saved a very significant number of strokes. And again, it's the first gesture, first attempt at becoming a population of outward-facing for-reaching organisation. That's something which we're extremely proud of. Like many organisations like us, and not particularly avant-garde, is the fact that we've moved elective orthopaedics, gynecology, gastroenterology into the community, and as constant we are replacing fewer joints, there are fewer outpatient fault tendencies to orthopaedics, and we're actually doing most of elective gynecology now in a local GP practice. So, and huge benefits to patients and their experience, huge benefits in terms of their outcomes, and huge benefits to the system in terms of amounts of money saved. And then finally, I would say that the other thing that we're really proud of is that our GPs now and community nurses go into the hospital 3 times a week. The community nurse goes there every day a week, 3 times a week. They're engaging with hospital consultants, therapists and nurses around the inpatient episode, helping to work out what the purpose of the referral was, of the admission was about, what the issues mitigating against early safe discharge, and the consultant and nursing colleagues in the hospital to manage care better in the hospital. And again, on the basis of that, we had a very significant reduction in length of stay and mostly medical readmissions. So not all these things are things which can't be done outside our model, but they've actually happened because of our model. And I'll hand over now to Matt to tell you a little bit more detail about how we've practically gone about doing this. Would you like, Baz, do you like to ask me a question?
Just a quick question about finance. Okay. So what you've said is that some practices saw an increase per patient of £20.
Yep.
So for a practice size of 8,000, they effectively were given an extra 160k.
Yeah, so we've got a practice of 24,000 who received £250,000 extra income.
So given the fact that 50% of CCGs are in turnaround, as a sort of Mansfield and Ashfield GP, where would that money come from?
It's come from a number of different sources. So it's come from the GP Challenge Fund, the Parameters Challenge Fund. It's come from our GP, primary care. What's the thing that it was kept back by the area team. There are transformation funds, money for primary care from the local area team, and it's come at risk from the CCG. Critically, it's come at risk from the main part of it from the CCG. And our financial situation is very challenged. And therefore, that's why this year, so the first year we levelled up to £83, this year we've gone to £90. And this year, a a large proportion of that extra incentive is pass-fail on the cumulative targets.
I'll just add to that. I mean, the CCGs have only got one pot of money, haven't they? They either spend it in secondary care or they invest it in primary care. And I suppose our suggestion is that it's in the CCG's interest to invest in primary care to reduce secondary care spend. It's still the same pot of money. And on one of the previous slides, it is true that our prescribing costs have gone down this year. It is true that for the first time in living memory since records began, our referral rates across the patch are lower than they were the previous year. So that is money that the CCG doesn't have to send to the hospital, which it can invest in its primary care service, because we know the future of the NHS, if it's going to have a future, has to be more in the community. There are other challenges, so I've just got a slide on challenges. I'm happy for any questions as we go, by the way, but other challenges that you and I will all recognise is the massive amount of information overload we have, the millions of emails. I'm reading a novel at the moment, the latest Jonathan Franzen novel, and I don't know if you remember 20 years ago there was that book, The 7 Habits of Highly Effective People by Stephen Covey, and he slightly lost credibility in my eyes when he published his sequel, The 8th Habit. But actually, in this Jonathan Franzen novel, one of the characters says actually there's only one habit of highly effective people now, and that's somebody who can keep on top of their emails. And so I think for me that's true. We're getting swamped with information from all over the place, CCG bulletins, Partners Health bulletins, but millions of emails from lots of people. We live in a system, we work in a system that we're trying to remember what we did last time, and probably the system's changed. How do I do an eating disorder referral now, this week, compared to last week? Lots of different things are happening all around us, and we just can't keep track of it all. There's loads more specialists in the hospital. There are now, in Nottingham, there are now 70 trauma and orthopaedic consultants. You can't possibly have a relationship with all of them, whereas 20 years ago, you knew probably half a dozen of the 10 that there were. Even within specialties, they don't know each other either because there's so many of them, and everyone's needing a bit more complex care. We're all struggling with time, finding time to meet like this. And we work in a system, unfortunately, where even if the clinicians agree, and that's often very easy to do within a system, you find that the money doesn't quite follow, and financial agreement seems to trump clinical agreement in pathway redesign. So what do? You either hang up your hat, or, as Einstein says, you have to think differently, and we cannot solve our problems with the same thinking we used when we created them. Some of it is obviously government created, but some of it is what we created. So Partners Health is informed largely, I suppose, through the GP 5-year forward view, in that a few practices were talking about clubbing together and working collaboratively within Rushcliffe, but the 5-year forward view made it very clear that actually you need place-based provision of care, and that you couldn't just pick and choose who you wanted to work with. You really had to work with who your neighbours are. So instead of a few practices decided they wanted to work together, we tried to create an offer that all practices would want to join in. So each practice still is its own sovereign practice as things stand, but we are all members of our limited liability partnership. And we try and make things as clinically focused as we can, because that's why we're here. Trying to create the culture to get that working. There were lots and lots of curries, coffees, all the rest of it, trying to walk the floor, trying to go around practices, get people to understand what the idea was, because the truth is now, for us in general practice, you can't just see your patients and go home again. We are going to be increasingly responsible for population health, and we do need to try and find time and energy for some of this extra stuff that isn't just the face-to-face in the consulting room. We have a lay chair for Partners Health. We focus particularly on pathways and outcomes, and we recognise that some form of clinical leadership is essential for practice to buy into it. The GP specification was a local enhanced service. It is a local enhanced service. That's the £90 equalisation thing. But for that £90, practice have to do more than they currently were. So it's not that the CCG are just handing over the money. There are quite a robust set of metrics which you can't easily wriggle through. So you have to deliver on to earn the £90 on the assumption, and it is an assumption at the moment, on the assumption that that means that less will be spent in hospital. To try and enable some of that, we've got our central System 1 resource for most practices, and we're trying increasingly to develop common operating frameworks within our running the business type practice model as well. So things like standardised claims, standardised recalls, standardised referral processes, these are all things that are works in progress for us. We haven't got a bespoke solution that we can just give you, but we are working on things. And we're trying to make it easy for the clinician to do the right thing. So we've agreed on how our clinical system looks. So if you're a doctor in one practice, you could go to another practice and you could log on and it would all look the same. We're agreeing referral templates with our hospital colleagues. And importantly, we're also creating our own performance monitoring. If we don't monitor, somebody else will, and you cannot manage what you do not measure. We've also, as Stephen said, created new models of working with some of our secondary care specialists within gynecology, orthopaedics, gastroenterology, to name the three. And they come on with there's some benefits spinning off from that in terms of education and ease of communication across the system. Sorry, this thing was flicking around. This is the thing, just to finish up with, this has been the most important thing for us. So we always had our CCG cabinet. We've shortened that meeting, and we've created our partner self-operational meeting on a Thursday afternoon once a month for an hour and a half. And this is where all practices come together as providers, and to share good practice, to share what they're thinking about, to share all this that they've done, but also to be faced with the metrics, I suppose, for want of a better word, in a supportive, encouraging sort of way. This doesn't come out very well, but this is a referral. It's supposed to have reds and greens. We've blinded the practices at the top, but actually in our meeting they're not blinded at all. And down the side there are names of our top 12 specialties, and you can see where you are as a practice. Here's another method of doing it. It's a very busy graph, but actually this is the thing that's motivated our GPs most of all, wanting to know where their practice is over the months since April for the different specialties, whether they're over plan or below plan. We've got similar things for prescribing as well, to try and encourage people to work within their budgetary means. So that's all I wanted to say from a sort of what we've done so far, but we're happy to take any questions, if there are any. So I'll give you a mic.
It's not a regulatory question for changing, it's a quality improvement question.
Yeah.
And I've heard you use certain language and buzz phrases which, to anyone who's got a background in quality improvement, will automatically recognise.
Yeah.
So I'm just wondering, could you tell us a little bit more about your approach to quality improvement and change as a group, where your capacity has come from to do that, and what that means in terms of you going forward?
Well, I'll take ours as a practice. So we have got some extra money through the enhanced service, which meant that we have been able to employ more GP session on time, which has meant that I can do a clinic session less a week to focus on some of this stuff, but also on trying to figure out what our population need, what me as a resident of Rushcliffe would like from the health service. And so part of it is around trying to quality improve our offer of primary care, but part of it is trying to improve the interactions that our population will have as they go through the system if they're referred. And so I think we would always try and look at what we think would work for us as a patient, if you like, as one for want of a better phrase. But Stephen, do you want to come in on that?
Yeah. If you're a professional in CQC colleague, like you were talking earlier, so you'll recognise that the domains of quality are safety, timeliness, effectiveness, efficiency, equity, and patient-centeredness. And in each of those dimensions, we can show benefits. So in access, we've introduced online access, and 32,000 patients now are regularly using it. In terms of efficiency and effectiveness, we've codified, we've come together as a group of clinicians, GPs and nurses, we've codified long-term condition management care. We've actually created templates which represent that codified clinical behaviours with read codes, so which now build digital population disease registries which we can interrogate and see where patients are not in receipt of all evidence-based interventions and not getting the outcomes which we imagine. And we can use registry management techniques to actually identify those patients who need to be called in. And we're actually using our Saturday morning service and our evening service, which is going live in April, to proactively contact them and bring them in, all those who are currently not engaged in formal care. So again, that speaks to safety, it speaks to equity, it speaks to effectiveness, it speaks to efficiency, and in terms of patient-centeredness, again, we can evidence a number of things which we're doing in that direction. Again, we're only going 15 months, so we're not out from cover, but we're trying hard.
Did I catch you right? Are you using the Institute of Medicine definition of quality and benchmarking yourselves and your services against that?
No, the IOM, the Institute of Medicine, defines quality in terms of its dimensions of safety, timeliness, effectiveness, efficiency, equity, and patient-centeredness. That's just a kind of organising framework against which we can evidence progress in each of those domains. We're not using it as a formal tool.
But that's your framework?
Yeah, if you'd like to help us develop that, that'd be great.
I think that's really impressive.
I'm just interested in the next steps, so and watch from the side and hugely celebrate what you've done. A year's not a long time. There's no if or but. It's just a genuinely. So what's next when we're here in a year's time? What will you be telling us about?
The poison chalice. So we've created an LLP. We are not certain that the LLP is the business model for the ongoing future. It might be, but we think we probably need to come back to that because it is easier to employ, and there are other issues around ease of running organisations in different regulatory frameworks, different corporate structures. From a quality and safety and all the rest of it point of view, we are developing more specialties. So, for example, respiratory and a different dermatology thing will be coming online in the next 3 or 4 months. And as Stephen says, our weekend service and evening 8 till 8 service will be going live from April 1st. For the MCP, do you want to mention that?
So, the bit of Gawande stuff wasn't just to tell you how erudite and how cultured we are. Gawande did coin the phrase about the century of the system, and that no one organisation within the system can fix the problems of the system on its own. So explicitly, Partners Health will be the voice of general practice within the Principia MCP, the multi-specialty community provider. So in 12 months' time, we'll have a much more mature, possibly expressed in contract, set of relationships with our secondary care colleagues, with our community services colleagues, with our mental health provider, and with other providers who can help us bear the load of patient need and demand more effectively. So I think there's some internal stuff about constantly checking that we're fit for purpose, but actually in terms of our organisational development, Partners Health will be the voice of general practice within the Rushcliffe MCP. And the Rushcliffe MCP will need to fit within the MCP structure which Hugh is developing in City, and James in Nottingham North and East, and Nicole and Guy in Nottingham West. I'm just conscious of time. I suppose, just if I don't get a chance to say this, Matt invoked Einstein. I normally grab cards off greeting card shops when I pass them in the shops, and mine are usually kind of much less intellectual. But there's two quotes which I often use which define why we've done this. One is the Gandhi quote, which actually has become a bit hackneyed because it's overused, and that's be the change you want to see in the world. And it kind of a bit whole another pie, but actually it's genuinely what has motivated us. We want to do that change. And the other one is from an Apple executive, I've forgotten his name now, that actually the best way to predict the future is to invent it. And what we feel as though we're doing is inventing the future. Within the parameters which we understand to be necessary, we believe we are genuinely inventing the future. And actually it feels thrilling. It feels thrilling to be doing that and not to be the victim. And I think I encourage you to think not necessarily on our lines, but in the context of your own needs and your own setup, what it is that you might need to do. And Susie, Matt, myself, we're very happy to help you any way we can.
Can I just ask a quick question, please? I'm really interested in how you compare the metrics between practices. I don't know how practices compare in Rushcliffe, but in some CCGs there's some quite significant differences, both in terms of defamation and in terms of the elderly demographic between practices.
So the metrics are all weighted according to the measurement leads for weighting our lists. So I have 10,000 patients, but I'm only paid for 8,800, I think, because of the weighting. So it's a similar weighting on the prescribing referral charts as well.
It's probably also worth saying that the range of variation across Rushcliffe practices is much smaller than that might be existing in Nottingham City, for example. So we have some advantages of geography.
So,
what do you feel is your single biggest hurdle that might have thrown you towards?
I think, well, for me, I think the biggest hurdle was probably the fact that, for me, very clearly the future was doing it all together. And if we're going to have a successful health organisation for Rushcliffe, it had to be the whole of Rushcliffe. And so you had to play with whoever's on the playground. You couldn't just go and create your little clique in the corner of the playground and hope the rest of everyone sorts themselves out. I mean, everywhere's got places, there's got people that are fantastic to work with and other people that are slightly harder. But you have to accept that, and you have to create a fair framework that everyone feels that they can join in with. So the hard bit was to make sure that everyone understood the 5-year forward view, that it was going to be that we needed to create something for Rushcliffe, not just for individual practices to become more efficient themselves, but leave others out.
Thanks so much to Matt and Stephen. So, in the time-honoured way, if we could show our appreciation, please. I'm going to invite colleagues from IMH to come up and take the stage. Okay, good afternoon, everybody. So, just before we start, can I just ask for a quick show of hands just so I understand, how many people have heard of IMH in the room? Okay, it's a good start. Hopefully you'll know a little bit more about us as we go through the presentation today. Just a little bit about who's here today and the way the presentation will work. We're going to focus primarily on what we're doing within our practices to change the way in which we're providing primary care for the 46 or so sites that work with us. We've got with us as well our Regional Medical Director for the North, Richard Bainham. Some of you might know Richard. We've got a Business Development Manager, Mark Taylor, and we've also got our Regional Operations Manager, Mike Fry, here as well. So what I'm hoping to do is run through the presentation in around 20 minutes or so, and then if you've got any questions, we'll direct the right question to the right individual here. Okay? These slides do look very small, but they're designed for a printout, and I think this is being published, Michael, is that correct? So it's being published, these slides?
We can share all the slides.
So you'll have access to the slides, and I'll go through them now. So the first part for us, as an organisation, it's important to understand what IMH are, and we provide back office services to individual partnerships around the country. We don't operate the actual clinical contract, the GMS contract. Okay? We go into partnership with the existing partnership through a service level agreement. And through that, our abiding direction, if you like, is to look after the patient care and the population of that practice. So we're not a national provider that only does national things and we're only interested in a certain practice at a certain scale and a certain size. We'll work with every practice that we come across to decide if we can add value to the patients in your practice. As I said, we're a UK-wide organisation. I think we go from Leeds all the way down to Bournemouth, from Herefordshire, all the way across to Great Yarmouth. And we're made up of 46 practices, over 200,000 patients, and that's located in both APMS contracts, for which we own and operate the Morning Health business, and also GMS contracts and PMS contracts as well. We also operate co-located urgent care centres, so we run the Dudley Urgent Care Centre. Richard will be able to give you more information on that. Regularly exceeds the 4-hour wait times, always in the top 5 nationally in terms of A&E attendances within 4 hours as well. And that's since the implementation for the urgent care centre that we operate. Crucially, David couldn't be here today, but David would normally be giving this presentation. He's our Chief Medical Officer. David's got a long history in both working in a corporate environment with TPG. He's also worked with some ambulance trusts as well. And he's worked alongside us in IMH now for around about 18 months since its inception. In addition to David, Maya Vibhuti, our Director of Medical Education, also still a practicing GP, works 2 days a week in a practice in Kent that's in the group as well. Maya currently is working with most of the deaneries in the country, developing an in-house INR scheme to be able to tutor, mentor, and actually get more international grads into the country quicker with our in-house recruitment team. So generally how it works, with the IMH, we have a regional clinical leadership team, of which Richard is the regional clinical director for the north, and then we have a regional clinical team for the south. And alongside that, we have regional directors of nursing and senior director of nursing as well. We also have a regional ops team that sit alongside the regional clinical team, who work with the clinical team to form an integrated governance committee and also manage the practice in an integrated way. So we don't separate out the clinical and the operational side of business. Within that ops team, we have compliance managers, business development managers, and we also have some systems analysts as well who provide the data for the clinical team in terms of patient outcomes. We've also got a service centre in Manchester who provide all of the payroll needs for the practices, HR needs, deal with all the insurance queries and actually providing insurance once you join the group. And then we've got a complaints management system and an incident management system called Radar Healthcare, which allows us then to report centrally on all incidents across the group, much in the way if any of you have used Datix before, which I'm sure you all have. Similar to Datix, but it's sort of like a Datix Lite. It's a little bit easier to use than Datix. That then feeds into the clinical governance team and gets reviewed for quality improvement purposes. And then we've got further back office services where we provide more payroll, more HR support, in-depth HR support. There's a local, each regional team have a local HR business partner who work with the operations and clinical team to make sure that they get all the support they need to develop the practice and the personnel in the practice. So as we've just heard, we don't see ourselves as the solution, we can see ourselves as part of the solution. IMH isn't for everybody, much like a federated practice model isn't perfect for everybody, or a super partnership might not be. We understand that, we're not trying to be the provider. What we're trying to be is, as I say, part of the solution to give people different options. And we think there's a need, as we all know, for new models of care. We know that the world is changing, we've just heard, it's all we seem to talk about these days. But on top of that, there's a succession trap issue. So what we're finding as we go around the country is that, guess what, new GPs don't want partners anymore. It's becoming a real issue, and partners are being left with partnerships where they're being left with 1 or 2 or 3 people in a partnership that can't sign a mortgage, they can't get a new GP to become a partner, and it's becoming a long-term issue for them. And then that leads on to the property trap. So partners generally in traditional partnership might have a lot of money invested in the property. How do you release that value in the property if you can't get a new partner to buy into that business? At some point, we're into a last man standing situation, and often there's no mortgage, no bank's going to touch you as a partner. You can't get that funding. How do you release that value of the property that you spent 30 years, 40 years building up? Okay. Over the moment. Okay. So what are the need for new models of care? Battery's gone. On tap as we go along. Okay, so we've all seen the King's Fund work regarding the pressures in general practice, and they tend to split them into patient, system and supply, and that's generally around access and continuity of care and improving care for patients. The system in terms of the regulatory piece, the relationship piece, and the new services, and the supply in terms of workforce and commissioning and funding. Okay. Now, the King's Fund isn't the only piece that we have to look at. As we all know, there's then the general practice forward view, which generally splits again into different categories. They do tend to become broadly similar, and they're all pretty much saying the same thing. It's investment, it's workforce, it's workload, practice infrastructure, and care redesign. So again, quite a bit of duplication in there. And in the care redesign piece, we've got the time for care, which when we look at the 10 high impact actions, again, generally fit into the same categories. Essentially, it's around designing new models of care, retaining and improving the workforce, and creating new clinical mix and new ways of working. So, in terms of what we're doing, we're investing in a centralised clinical triaging system. Now that will basically allow us to manage demand, improve practice resilience, and allow us to operate on a national scale without being local, at scale. Okay? Now, what that allows us to do is standardise the level of care that we provide, because we'll have a central team triaging and offering telephone consultation, support and advice. We'll have improved standards, because when you've got a smaller team, you can ensure the quality and the standard is replicated across the group. And a wider clinical mix, because if you're operating at scale, we can then potentially bring into that CPNs, we can bring in pharmacists, we can bring in physiotherapists to give phone advice and support people remotely. It'll be flexible enough to allow us to change to the individual needs of each practice, because we'll have the volume, and it'll give improved resilience, because we'll be able to support and put extra resource centrally if we have an issue in one practice where a partner goes off sick for a long period of time or an employed GP goes down. We will reduce reliance on our locums and our locum base. And that will improve access. Our practice currently, most of them are in core hours. The central triaging system and support centre will be open from 8 to 8, Monday to Friday, plus weekends. So that's how we work in very basic terms. It's very much like a one-on-one service, an out-of-hours service, just in hours. The patient will call up, they'll be streamed or triaged by a team of receptionists, nurses and GPs. From that point onwards, through the use of using Adastra and Odyssey, we'll be able to then integrate the IT into the practice. And that means when the patient calls and gets triaged and goes through the triage process, we'll be able to also put the appointment in the practice locally if it requires an appointment. That's a crucial difference between a lot of the models out at the moment, which then require practice to then report back to the patient. That then links into the practice system. As we say, the patients will be able to be booked directly into the practice. Other stuff we're doing, which I think most people are doing at the moment, online presence. So we go live with our first online consultation website later this month. Should be a week on Friday. Essentially using online consultations that go straight into the clinical system, create a task for the GP or the nurse to call that person back. Over time, they'll be dropped into the triaging system. So those online consultations will go to the central resource who will pick up that first triage and then decide if it needs to be put into the practice. Also, the remote self-care support, working with MJOG to develop smart text, which are, I think most of you might know are coming from MJOG pretty soon. More or less will replace email. And that will allow us to send out reminders to patients, but as well as that, we'll be able to collect information prior to them coming into the appointment, which will then get coded into the clinical system. We can then also, with MJOG Health Monitor, which some of you may know about, make sure we do some diabetic patient management, for example, remotely. We might want to send them a questionnaire every 3 months. Again, that can be coded so their responses go straight into the clinical system and alert the doctor to anything that might be unhealthy for the patient. The other pieces we're doing really centre around the workforce and the clinical mix. We actually went down the route, if being completely honest, about a year ago of changing the clinical mix in practice, and we've done that. We're using now pharmacists. It's nothing new, quite a few people are doing it. Prescribing pharmacists, pharmacy techs, physiotherapists, home visit practitioners, ECPs, various different people in the clinical mix. But what we found was, without a centralised and standardised triaging system, where people knew which patient to book with which specialty, it was difficult to really get benefit, both financial and patient outcome-wise, out of that system, which is why we're investing in the triaging piece now. So we've got the clinical mix, we've got a central recruitment team. They've currently brought in over 70 GPs in the last 12 months to the business. They are working the international picture. They're bringing INRs. We've got quite a few INR schemes running. We've just placed our first candidate, I think, Mike, is that right, in Nottingham? Yeah. In our builder practice. And again, they don't only focus on the recruitment, it's the retention and the well-being after that as well. So our HR team pick up after the recruitment team as well. Still good. So that's what we're doing. A little bit more around the succession track as we see it. We know the traditional career path for a GP is training, salaried, and then partner. That's the traditional career path. It's not always the path that people follow, but traditionally it is. And there's a lot of business risk for the partner because it's a business at the end of the day. There's a long-term commitment to that as a partner, again, and it's relatively inflexible. However, historically, I say historically, there was a better earning potential. So the benefit for the partner was, A, you got to control your own business, you got to look after your patients the way you want to look after your patients. You took a financial risk, but there's a financial reward for that as well. And what we're finding increasingly in the current reality is that financial reward is diminishing year after year. In actual fact, I think the latest study is that employed GPs tend to earn more than a partner because they're then going to locum on the days off. The other problem with this career path, as we see it, is the value is created in the property. So the value of that business that you've created over the last 30 years is created in the property that you own. Okay? Yeah. Thanks. In terms of portfolio careers, this is the new career path that GPs are looking for, which most of us are aware of. It's less linear. It moves in various different directions. GPs complete their training, they might go onto a salary position, they They might go on to further specialty or training. They might go and work 2 days in a UCC. They might go and work 2 days in another part of the hospital. They might move abroad. I think over the last 4 years, certainly between 2002, 2009 and 2013, the number of certificates of good standing to allow GPs to go and work abroad doubled. We haven't got any numbers from since 2013, but the general feeling is that will be higher again. One thing we can do is offer GPs the opportunity to have those portfolio careers, because we operate walk-in centres, we operate urgent care centres, we operate co-located services as well, secondary care. Which then leads us onto the property trap, and this, to be honest, is one of the key reasons why we think there's a place in the market for IMH. You want me to read this? I'll read this out for you. Partners are increasingly struggle to realise the value of the property. Again, when a partner, there's only 3 partners in a partnership, and one partner wants to leave, there's 2 partners left. When one of those partners leaves, there's going to be an issue about what happens to that property, especially if you can't bring in a successor or a new partner into that business. Who signs up to the new lease? Often, as partnerships have evolved, there is no lease. We're working in a practice at the moment where there's no agreement between the partners as to who owns what part of the business, the property, and there's no lease signed between the guys within the partnership. So a partner might have left partnership 10 years ago, but they still own the building and they're receiving a rent off the partnership itself, but there's no lease between them. There's no legally binding anything for that to happen. Trying to do that is very difficult for a partnership. GPs, as we said, no longer aspire to join partnerships. It's quite a broad statement. There are still quite a number of GPs that want to join partnerships, but there's very few that actually want to buy into the value of the property or can afford to buy into the value of the property. And as freehold partners retire, we said the remaining partners are unwilling to sign those leases because the remaining partners might be 50 years old. At the age of 50, 55, are you really going to want to sign up to a 21-year lease to release the value of your property? Again, you've probably seen some of this information. The RCGP wrote to Jeremy Hunt, 467 practices in England have 75% or more of their GPs aged 55 and over. Now, where those guys own properties, again, where's the solution for them? So, what we can offer in terms of the property track, we can unlock the sell and lease back opportunities for the partners. We're enabling the new partnerships to sign a long-term lease, and when I say new partnership, we don't enter into a new partnership. Some of our executive partners join your partnership, but they will sign the long-term lease and you will get indemnity from any risk on that. As it says there, it removes all the lease liability from the existing partners through this legal process. And that releases the value of the property for the partners. Now, the property piece is a little bit more complicated than the 2 slides we've gone through, but every situation is different, so I don't want to give you an example of how it works, because it will be different for every single individual partnership. So I'm hoping that helps clarify what IMH can offer, and if you've got any questions, I'll go and stand over here, and then I'll pass the microphone around to the right person, depending on what the question is about. Okay.
Workforce and training,
Yep.
which people in the audience won't be surprised I'm asking. I don't know much about your organisation, so I've learned a lot, and I think the property issue is probably something to explore. I know that's a big worry for a lot of people. But in terms of workforce, I think I was particularly interested and pleased to hear that, because I don't hear that mentioned as often as I think we probably ought to be doing. Not only about succession planning, but the portfolio careers. So I just wondered if we wanted to know more about that, how would we find out more about that, and what lessons have you learned from that beyond what you put on the slide?
I think what we'll probably do is just put our contact details on the front slide as well. So if you want to talk to us about workforce and planning, then give me a call. I'll give you my card later, and we can have a chat about that as well. And I can put you in contact with the right person. And similarly, if you want to know more about the property piece, Mark's here today. We'll be around for the next few hours as well. So if you just want to grab us to one side, and clinically, Richard, as I say, most of you know Richard and are aware of where it was passed in this area. So if you need anything at all, just ask Richard on that basis.
I'm interested in relation to the triage system, whether you encountered any information governance, data protection issues, because that's commonly one of the big barriers to that sort of system.
Yeah.
So how did you overcome those kind of issues?
So one of the key points to raise here is that it's still in its trial period in one site. Okay, so we're saying we're going to have it, we haven't got it at the moment. It depends how we structure it when we talk about it today, whether we decide to structure it as a location within a partnership, and then other services operate or have an agreement between that partnership and work on that basis, or that we set it as a legal entity in its own right. So that's the bit we're still exploring, but you're right, that's a pretty big headache for me at the moment.
At the back over here. This may be a silly question because you may have covered or explained this within the presentation, but I was just trying to work out what the relationship is between you and the practices. Are you a super partnership? Are you a federation? I just couldn't quite grasp that.
Yeah, I'll pass you over to Mark in a second, so you can correct me if needs be. So the way it works is we're a group of partnerships. So we're a group of partnerships, and the partnerships sign a service level agreement with IMA to provide their back office services. Okay. Individually, each partnership remains its own legal entity, and two of our executive partners join the partnership, and that's how they basically have an influence over that partnership within the partnership agreement. But in their own right, we're a group of 16, the simplest way of explaining it is we're a group of 16 partnerships plus Morling Health, which is a limited company.
I think I understand. So there's a sort of there's a partnership of your executive partners who then, so your executive partners are on the partnership agreement of multiple other individual practices.
Yeah.
Okay. I'll sort of still continue to try and understand.
Well, what might also help is the partnership gets divided into two levels, and it's an executive partner and a fixed equity partner. And the fixed equity partner will be the old partners, and that's what releases them from liability in terms of lease and other bits and pieces. Yeah, I mean, we have had a couple of practices go through this because obviously, as you can appreciate, we take practices as partners want to retire. That's one of the things we actually do quite a lot of. When old partners go, we're obviously left with two executive partners on the partnership. When we try and recruit back in, we will try and recruit more fixed equity partners into the partnership. But again, because we're limiting their liability, they don't have the liability of the lease or any financial risk. That sits with the executive partners.
Okay, I think I understand now. Thanks. And it does sound like a reasonable, viable model. I'm not being critical by asking this question.
Yeah.
Just a point of clarity, what's the difference between a salaried GP and a fixed equity partner?
A fixed equity partner is a self-employed individual. So they are taking, they're not under our supervision, direction, control, which is essentially the main difference. So because of that, they've passed the test for IL35, which means they're a fixed equity partner. And they also have a say in the partnership agreement. The executive partners don't have complete control over the partnership. That's not how it works. It still is a partnership. The clinical partners, fixed equity partners, still have a say in what happens. It's just if it comes down to a financial decision which is going to disrupt the running of the practice, then the executive partners would have the right to veto any decision.
You're taking profit share.
So the executive partners or the clinical partners? Clinical partners do take a profit share, yeah. With every partnership we sign into, we agree a profit share agreement, so the practice has to make X amount of money, and anything above that amount is then distributed amongst the clinical partners.
Hello, I'm an accountant, not a GP.
Okay.
I've got a portfolio of thousands of practices.
Hang on a second. I'll give you to the accountant.
Oh, thank you.
I think you suggested that the partners are earning less than salary GPs if I heard you correctly. Correct me if I'm wrong.
Yeah, no, that's correct.
That's not what our stats are suggesting.
What we're finding increasingly is that partners still count the property income as part of their income, whereas really, in real terms, that's just the return on investment that they've invested into the property. And there's one partner that we've looked at recently. On the face of it, the partners are all earning very nice profits, earning about £150,000. By the time you take out 70,000 each of property income that they're receiving, it's 80,000, which is slightly more than a salary GP, I'll be honest, but not that much more. And if the salary GP is doing a day or two locum, it's quite a bit less. That's what we're finding.
Even taking out the rental income, the figures are not suggesting to us that the salary GP rates are greater than profit on average. I understand it's different in different areas.
Yeah, well, that must mean then the partnerships that are coming to you are obviously slightly different to the ones that are coming to us. And that may be the reason they're coming to us.
I think the biggest difference is clinical partners do a lot more hours. And actually, if you get paid per hour, it actually works out you are getting less as an income.
Yeah, totally agree that the hours are an issue.
Yeah.
Agree with that, but in terms of profit and rental return, the income
Could I just add to that? I'm not getting a suggestion from you that the partners' clinical payouts are reducing by being members of your partnership.
Yeah.
Yes, they are. They have set hours. So, they will work a 40-hour week.
The main difference, to be honest, is that the partners become clinical partners. They stop being business managers, business owners, property owners, recruitment agents, payroll supervisors, HR consultants. That's what the job of a lot of partners is at the moment, and we take that away. That's what we do.
So how do you work 40-hour week and that isn't what's in the contract?
In what contract? So in the...
Because we're not talking about salary GPs, we're talking about partners. How do you live your week 40 hours?
So the partnership is drawn up with two documents. One is the partnership agreement, so that's the partnership agreement, and then there's a partner contract that sits alongside the partnership agreement. So there is a contract that sits alongside the partnership agreement. It is a different model from what almost everybody in this room will be used to, but that's the model that we use. And to take Mark's point, if you think about as a partner now, how many hours you spend doing stuff that isn't clinically related, that's what we take away, and that's why we can say we move the hours down to 40. That said, to be completely honest with you, that's a 6 to 12 month process. I think Michael will agree with me. It doesn't happen overnight. There's a lot of change that needs to go into these projects, which is why we only take around, historically it's been around 6 or 7 practices a year.
I was just wondering what proportion or sort of percentage roughly of partnership income goes out of the partnership to the sort of executive partners and the umbrella organisation in return to the services which you are providing in terms of recruitment, back office management and so forth. But how much does that cost the partners that are still there in practice?
Honestly, completely honestly, we're not making any money out of the GMS side of the business at the moment.
But I wasn't really asking about what money you're making in terms of profits as an umbrella organisation, just what
operating contribution from a practice.
Yeah, out of the practice.
There's no time, and having practice, some of the practices are actually
they're costing us
money to run. But we have an APMS business inside, which actually allows us to fund those practices in the short term until the sustainable long-term care delivery from it.
What are you charging the practice? What do we pay per patient? Or?
per population, or how do you charge the practice?
So the practice don't get charged per se. The contribution that the practice makes comes to IMH. After a certain point, and that's decided based on each practice, there'll be a profit share amongst the fixed equity partners. So if you imagine your operating contribution basically is £1,000 a month or £2,000 a month, that's what we charge you for our services. Once it gets to a certain level, which we agree, is then a case of sharing that profit amongst the fixed equity partners. Does that answer your question? We can't tell you without sitting down and going through your accounts with you and working out, because there's various other bits and pieces regarding whether you recognise your rent as income or not. There's various other bits and pieces we need to go through. We can't just say that. What we basically say is, whatever the excess is, that's what IMH's fee is for the time being, up to a certain amount. When it reaches a certain amount, then we take a profit share amongst us and the fixed equity partners.
Does that mean that the bigger practice that goes into your system, the less money you get from it, if it's a share of that profit?
Again, it depends. There isn't a model that works because every practice is so different. Do you have a better way of explaining than me, or
a better way of explaining?
I'll be completely honest.
Okay, effectively what happens is the practice operates, revenue comes in, I pay the fixed equity partners and all the staff and all the utility bills, everything. The money that is left over at the end, which is actually the profit, is what is charged out as a service charge by the service company. That's how it works. Now, as we said, in many cases, actually, because of the model of GMS and the mess that it's in at the moment, that's actually the other way around, in that we're putting money back into the partnership to keep it operating. Long term, that won't happen. But for now, that's what's happening. So we can get in the new models of care, the triaging, and the new skill mix. I don't know if that answered your question at all. It is very complicated to explain, Ben. I can sit down with you after this and we'll run through exactly how it works. But without having a slide or a spreadsheet to show you, it's quite difficult.
I think also it is a case of, I can't overemphasise enough how much every practice is completely different, and we need to sit down with you and go through what you recognise as income, what we'd recognise as income for a starter, and then just go through your costs and understand what's happening, what your expectations are in terms of earnings as a fixed equity partner. There's so many variables in there that to say it's X or it's Y is impossible at this point in time.
I just want to ask a question about closing down surgeries. So I think you said you had 46 and you took on 6 a year or thereabouts, so that was manageable. But I guess at some point, presumably that's an awful lot of building outlets. So have you closed any surgeries, and if you did, what happened to the fixed equity partners when you closed the building which they traditionally worked in?
So in regards to GMS practices, we haven't closed any surgeries, and if you think about the way it works, our executive partners sign up to a 21-year lease, which is what allows us to release the sale and leaseback value for the existing partners. So for us to give back that, then we'd have an onerous lease sitting over us for the rest 18, 19 years, which is not something that we look to do. So there's no intention for us to close any GMS practice ever. What we look to do is implement a central triaging system so that we can then change these small partnerships or large partnerships that aren't working so effectively and potentially offer a new model of care which makes them effective and also profitable for the fixed equity partners and ourselves. We have, being honest again, closed make MS contracts, and I think that's a reality for most people who provide MS contracts, in that the dwindling income around the country is causing us to actually have to hand some of it back. Okay, thank you very much.
So again, a really interesting model and good. There was lots of questions there. I must admit, when I first came across it, and it's come to our county, and 2 practices now are being run by RMH, I did think about it almost as kind of GMS or PMS by stealth. That's kind of how I saw it, and I found that really interesting. So I think it just shows what's possible, and some of the principles, because we've discussed what you do and how you work, and those principles are operating at scale and are thinking about how you develop your team and patient care within that. I think those are the other bits that maybe didn't or could come out more, and really it's for practice to think about how they either get on board with that idea or maybe replicate some of the principles, because there's clearly some good things that you're doing there as well. So we're moving on to the third presentation here, and I'd like to invite, just a little bit further back, a colleague from Somerset LMC, Dr. Harry Yoxall. Really kind of long way to go to come here today, but really interesting some of the work that's going on in Somerset, quite different to some of what we're doing here, and I've seen the slideshow and it's some good entertaining stuff. So we're going to hand over to Harry, and really looking forward to hearing about another area of the country with the same kind of challenges we have, and hearing how you've tackled it there as well, Harry. Okay?
Is that all right? Well, thank you. Good afternoon. I like race courses. We have our LMC meetings in Taunton Racecourse, but I can cycle to that. It was a little further to get here. My son would have done it, but 100 and something miles is more than I can do. So what have we got to tell you about general practice from our damp corner of the southwest? Some interesting things, not at all like what you've heard so far. We have a small GP community, and we do things a bit like they did them in the 1950s sometimes. So is Somerset different? How does it compare with large Midland counties, and particularly with urban centres? Well, it's rural. We've got a scattered population. It's one of the most rural counties in the country. And that means we have small population centres, small practices spread out over a wide geographical area. Communication's reasonable. The M5 runs straight the way through the county, but once you get away from that, lots of small lanes. Our secondary care comes from a DGH, Taunton and Somerset, medium size, got most specialties, got a cancer centre now, angioplasty and so on, but our tertiary care has to go out of county. It's a big, and like most trusts, unfortunately, showing a deficit. And we have a smaller DGH on the other side of the county at Yeovil, third or fourth smallest in the country. Here's one of our strengths. We have got one CCG to cover the county, one LMC, and we have the same boundaries as our county council and the foundation trust that provides community and mental health services. You have one set of relationships, and I know this seems almost incredible to some folk when you're trying to do with dozens of CCGs and organisations, but that's our strength. Most of our health economy is internal. We have people who refer out on the boundaries, and on the other hand there are a few patients from across in Dorset in particular who come in, but for the majority we have an internal health economy, so when things go horribly wrong, it's all our fault. And because we still live in 1950 and we have a rather nice steam train that runs through part of the county, we have remarkably good working relationships between the different parties. Partly because we've all been around for quite a long time, and partly because when there aren't very many people, you just have to play with whoever's around. And perhaps the most interesting aspect of this is that in the last 20 or 30 years, we've had some really very visionary leaders. Not every NHS manager is in this category, but a lot that we have managed to find have been, and they have brought innovations and initiatives that we've managed to maintain. So, 72 practices from the quite small to the quite large, but interestingly, they are clustered together, partly by geography, but partly for historical reasons. We were an early adopter of out-of-hours care arrangements back in the 1990s, and as a consequence we didn't establish a sort of county-wide organisation, but there were small clusters of practices who were able to collaborate, and that model has persisted. And these developed into cooperatives, and those cooperatives were eventually subsumed into the commissioning organisation when CCGs were formed as sub-localities, and they've now become provider groups. But they're groups of practices that have a tradition of working together. And the other great advantage is that we are almost exclusively EMIS. 70 of the 72 practices are or are about to be, and by this time next year the whole county will be EMIS users. So lots of good things. Cream's good and the cider. But we're getting old quickly. We have a third more over 75s than the national average, and 1 or 2 of our wards have the oldest populations in the country. And the population is ageing rapidly, and that's an enormous challenge. As I've said, our largest town is about 65,000 people, so we really are dealing with small populations. And we've decided one of our challenges with recruiting young people is that we have no university and we've got no cities. There are no bright lights to attract people, so young professionals don't necessarily want to come to a part of the country where their partners, life partners, may not find it easy to find occupation and employment. And like most places, our health economy is in deficit. So, as you all know, levering change when you're in deficit is challenging. Changing in the NHS is like taking the wheels off a racing car whilst the race is still running. In our situation, it sometimes feels like taking all 4 wheels off the racing car whilst the race is still running. We aren't terribly diverse. Here is my chairman. We are indeed wearing the same tie from the same institution of ancient learning. He is long-sighted and I'm short-sighted, and the checks on my shirt are larger, so we aren't at all the same. But it is a fairly homogeneous population. Well, where are we starting from? Some of you may have heard of something called the Somerset Practice Quality Scheme, which was launched a few years ago with a certain amount of excitement in the press as an alternative to the Quality and Outcomes Framework. And this was started by a very visionary NHS area team, local director, who said, look, you guys are always grumbling about QOF, go away, come up with something better. So we did. And the principle was to move away from the tick box elements of QOF and try and develop something that was actually going to be more fruitful in the long run. And it focused on 3 areas: sustainability, trying to make sure that our general practices still around in 5 or 10 years' time; integration and joint working with other organisations with a long-term view of trying to stitch the NHS back into a genuinely coherent local organisation; and finally, patient-centredness, trying to make sure the services we were offering to people were what they wanted, not what we were imposing. So people were genuinely able to make the decision: am I going to take the statin or am I not? How do I balance the evidence? Rather than what tended to happen was, you're in the category that says you ought to take statins, here's the pills, goodbye. 2/3 of our practices took it up, and that was largely done according to these federations, these localities we've touched upon, because the collaboration element meant that you needed to have enough practices in your patch who were working in the same way for it to be functional. It's been a very interesting exercise. The outcomes so far have been inconclusive, I think it's fair to say. There have been worries that because we aren't doing the numbers, that the quality element of care may not be being observed as closely as it should be, and certainly the reported QOF figures have dropped off. But we've got no evidence of harm, and there are some early indications that patient-centredness has increased, and certainly the integration and sustainability work has been significant, as you'll see. The other big thing that happened was something called Somerset Symphony, and this started with our smaller DGH recognising that because they were small, they were under constant bed pressure, and fluctuations in demand had a much bigger impact on them than they might have done on a large DGH. And their recognition that if growth of activity increased at the rate at the time, they were going to need 2 whole new wards within the next 15 years. And since beds were rapidly being closed at the time, that was clearly unrealistic. So they felt it was sensible to talk to people about a more collaborative approach to healthcare. And Symphony sponsored some very, very interesting research looking at what it was that made people likely to be admitted. And the answer is the number of long-term conditions that you have. And you can rank the significance of those conditions, but basically if you have 3 long-term conditions, then you're much, much more likely to end up in hospital. that kind of stands to reason. We sort of knew that intuitively, but actually writing it down and expressing it at last gives us a lever on what we can do to try and stop people going to hospital. If you look at the patient population, about 4% of the population fall into this highest risk category, and about 18-20% fall into the next category down. Now, if you then design services that are going to work to support those people and keep them out of hospital, then ultimately you can make savings. And the idea was that we'd have a complex care hub, a physical centre that would coordinate the management of that top 4%, and then something called enhanced primary care for the next 18%, and we'll come to that again. And the object really was to try and do away with the boundary between primary and secondary care, which is unnecessary and artificial. It just happens to be there because of the way the NHS was set up in 1948. And this was going well, but the real prize, the coup, was to get Vanguard funding a couple of years back, which has given the whole thing an extra boost of initiative. So how does it work? Well, the idea was that Symphony, this organisation, would have a relationship with its local practices. They recognised that particularly smaller practices, particularly rural ones, were under some pressure, and they came forward with a plan to integrate those practices into an intermediate organisation that sits between the Foundation Trust and the rest of the NHS. It's called Symphony Healthcare Services. And practices that chose to join that would have their contracts essentially suspended, taken into the organisation, but the existing partners would have the right to take their contracts back out again. Now, the practices that have integrated so far have tended to be those where the partners were evaporating in the way that they tend to when times are very difficult. So it's unlikely, we think, that any of them are actually going to want to reclaim their contracts, but in theory, that's an option. The other practices in the locality were invited to participate, and that would mean forming a much closer relationship with the DGH, and also there would be an element of profit sharing, risk and loss under some kind of an alliance contract. The other two foundation trusts that we have, both the Community Trust and the other big DGH, have also been talking to local practices, not necessarily on this basis, but with a view to absorbing some of them to maintain primary care services. And the Foundation Trust that provides community services is particularly interesting in this regard, because their medical director said, we don't particularly want to run primary care, but we don't want to see primary care collapse, because if it does, we're the folk who are going to have to pick up the pieces. And likewise, the DGH, with a large A&E department, had a much the same view, saying, if you disappear, our ED will be swamped. So we need to be there to help maintain primary care. So they're not approaching this in a predatory fashion. Right. Back at the ranch, the CCG was talking to everybody about outcome-based commissioning. Slightly out of fashion since the debacle at Cambridge, but the principle, everybody agrees, is sound. Instead of incentivising people to do stuff, you incentivise the health community to come up with results. And the best example I've come across is the idea of HIPs. You don't pay a hospital trust or a health community to do hip operations. You give them a target to, say, make 90% of your 85-year-olds independently mobile. You don't tell them how they're going to do it. Some of those people will need hip surgery. Some of them will need intensive physiotherapy treatment. Some of them will need medication. And one or two of them may just need a mobility scooter so they can get to the pub. Because what independently mobile will be determined by is the patient's interpretation, not the medical model. So it's quite an exciting way of looking at things. So they decided they were going to build this thing called Somerset Together, which brought together something like 2/3 of the healthcare budget under the umbrella of Somerset Together. This would absorb quite a lot of the commissioning function, because if the commissioners aren't constantly checking the numbers, making sure you've done the right number of hip operations and paying, they're handing over a capitated budget against a set of outcome measures. You don't need a lot of the people within the CCG and NHS England. Now you can't do this overnight, of course, and you'd have to move forward slowly in a small percentage, something like 5% in the first year. It's a big move and a big change, and we were all quite excited about that. We thought that there were real chances. And then, of course, along comes the STP. Fortunately, the model is very similar to the one that we were developing, and here is somebody called the Running Man. If you go down the M5 to the West Country, you're passing between Bridgewater and Weston-super-Mare. He's running westwards. He's now, unfortunately, surrounded by houses, but he is still there. It's a bamboo sculpture, rather beautiful. So, yet again, Somerset has miraculously managed to maintain its own health economy. Very conveniently, we don't quite fit with Bristol, and we don't quite fit with Exeter, and we certainly don't fit with Bournemouth, so they kind of leave us alone to get on with it. So we've yet again pulled off the magic trick. And the principles that the Symphony model envisaged, which were based in South Somerset in Yeovil, are now being extended to cover other parts of the county as well. The model of the Complex Care Hub being a separate organisation for that top 4% probably isn't going to work out as we'd originally thought, and it's likely that they will be subsumed back into general practice. I think it's been a very interesting experiment to see where is the best place to provide care for even quite complex sick people. It's in general practice. We knew that, but it's nice to see it confirmed. And something called patient activation is now becoming a very significant and useful concept. There's something called the patient activation measure, which is an American idea. It's been patented, needless to say, so we have to pay for licenses to use it. But it's a tool that you use to measure how involved patients are with their own health care. And there's some very good evidence that the most engaged patients are much less likely to need hospital admission. They're much more autonomous, much more in control of their own behaviour, and they need far fewer health interventions. And encouragingly, if you can make people who are at a low level of activation more interested in their health care, they acquire some of the benefits of the people already at the top. So it's not just a cultural, class, education, status type thing, saying that, well, of course, if you're yourself a doctor or a professional, you're going to be more activated than somebody who doesn't have those advantages. You can actually shift the whole population's involvement upwards and save money. Enhanced primary care, then, we touched on. What's that all about? Now, this is blindingly simple and incredibly effective. What you do is you recruit health coaches. And these, as it says on the slide, are not health professionals. They are people from the community who have the combination of empathy and good common sense. And those people can very quickly acquire the skills to help the practice support a range of individuals with a range of healthcare problems. And they come from a big range of backgrounds. We've got health coaches who have professional qualifications, and we've got health coaches who have done no formal education beyond secondary school and who previously been working in the village shop or have been practice receptionists or healthcare assistants, but simply have the right skills and attitudes. And their role is to help people self-manage. It's to increase their activation and to make sure that people can remain independent. And all the GP clinicians in this room will be well aware of the patient who really ought to be able to manage at home. They just need a bit of sensible help. And where do you get it? Social services don't do it. It's not a healthcare responsibility. There may not be a relative. The neighbour's gone away to Spain. You just need a little bit of help with somebody. And that's exactly the sort of thing that health coaches can do. And they are integrated into the rest of the healthcare team through this thing called the huddle, which is basically a semi-structured meeting that you hold 2 or 3 times a week, and you bring your frontline clinicians, your GPs and your practice nurses, nurse practitioners, and the health coaches and all the other interested parties together, and you have a list of patients who are likely to need intervention, and you discuss the care that they may need. The terminology is not fixed. We call them health coaches, some people call them health connectors, health supporters, but we are beginning to identify a slightly different role, the health navigator. And the health navigator does what it says on the tin. They help people navigate through the complexities of the healthcare system. So it's a slightly different function, but the two certainly overlap. And interestingly, where we're starting to trial this, practices are using these individuals in rather different ways to fit their local needs. So their main role then is coordinating care for these patients, and they fall into two categories: those patients who are at the highest risk end, who may need to have regular telephone consultations, and it may be a simple checklist reminder: have you taken your pills? Have you checked your blood sugar? Is there anything that's worrying you? Did you remember you've got an appointment to see the nurse? Can you not get to see the nurse? Shall I come and collect you to bring you in? Those sorts of things. And at the other end, there will be those patients whose lives are chaotic or difficult, who may end up being more demanding of NHS services, who don't necessarily need that high level of medical intervention. Patients sometimes with medically unexplained symptoms or personality disorders, who are lonely or have become dependent for some other reason. And a significant number of patients like that can have much of their care provided by a health coach or a health supporter. They don't need the GP. And the evidence is so far that we can achieve a significant transfer of care and attachment away from the GP to a health coach. And one thing that's interesting is the value of crisis support in admission prevention. It's a good example quoted by a health coach to us just a few days ago, who said there was a schizophrenic patient who was about to be evicted from his home because he'd left it in the state. And the landlord said, I'm not having this chap in my accommodation anymore. He's leaving everything a mess, he never keeps anything tidy, he's not keeping the terms of release, I'm going to evict him. So he's evicted. What would happen? Almost inevitably, he would end up back in hospital because the stress of the eviction might well precipitate an exacerbation of his mental illness. And anyway, what else would happen to him? The system really isn't designed to catch him if he fell. So the health coach literally rolled up her sleeves, went round, recruited various friends and family, got involved with local mental health charity organisations and support groups, went and organised for people to sort out the house, get it cleaned and tidied. The mental health charity came and helped him redecorate, found him some new furniture. That gave him much more self-esteem to feel that he was in a respectable place again. The landlord was absolutely delighted and said there was no question of evicting. In fact, he was going to extend his lease. And he's become a model tenant. Now, it was the intervention of the health coach that turned what was an inevitable disaster into what we ought to regard as a success story. That's Porlock Weir on the North Somerset coast. Lovely place. Good for holidays. What direction am I supposed to go?
Does it work?
Right. So moving on to some of the other things that are going on, we have a home visiting scheme that's been set up in part of the county, and it's in Minehead, just along the road from where that picture was taken. Now, this is the sort of thing that you can do at small scale, and I know the previous speakers were talking about much larger scale activity than this. But suppose you had a smallish practice or a group of practices and you wanted to do something now to make your lives easier, what might you do? And what this little group of practices did was to recruit 3 emergency care practitioners from the local ambulance service. We aren't terribly popular with the local ambulance service for stealing 3 of their highly skilled emergency care practitioners, but I'm hoping to be forgiven. And what they did was they recruited these 3 and they said, what we want you to do is to provide a visiting service so that the majority of visits that are requested from that group of practices will be undertaken by the ECPs. It's been extraordinarily successful because the doctors are not having to leave surgery, particularly during their normal consulting times to go to emergencies. But even the routine visits that fall in the middle of the day can mostly be undertaken by the ECPs. It's a tremendous saving on time, and particularly because we have small, in some ways old-fashioned practices where there is a duty doctor who's carrying much of the burden. That's far less stressful if you don't feel that I've got to rush out in the middle of surgery to go and do something. The evidence is that the service is good and has been consistently safe. It is true that ECPs often take longer to assess patients than a GP would, but they're much more thorough. Training is now being provided in-house because two of the practices are training practices, and one of the trainers is particularly interested in multidisciplinary training. They are able to provide very good training in-house, and they've linked through to the GP Education Trust, which is now the core of our CPEN, and that's also going to provide special training for paramedics and ECPs who are now beginning to work in primary care. So you don't have to have a really complex organisation or to have a great deal of time, money or initiative in order to make changes in the way your practice runs to benefit both the practice and the patient. And interestingly, at the moment, indemnity is provided by their professional body. And one of the problems we have with a lot of these new models of care is how you indemnify. And in the Southwest, we've been doing two things. One is that we've been using the offices of our Academic Health Science Network, which covers the three counties of the Peninsula, Cornwall, Devon and Somerset, to look at whether it would be possible to procure indemnity cover for the whole of that sub-region using NHS procurement. And that's been of some interest to NHS England centrally, as you might imagine. And we are proceeding with that gently. But we're also looking at locality cover so that a group of practices will go to the same MDO, MDU, MPS, possibly MDDUS, and say, we wish to get indemnity cover for the whole of our locality for our population, because we're changing our model of care and we don't want to be tied by the individual doctor rules that say you must work X number of sessions and only a certain number can be in-house or out of hours, and you can't do this and you can't do that. And we've had a very positive response, certainly from one of the MDOs, into that sort of suggestion. Moving rapidly on. Clinical pharmacists. Has everybody got a wave 1 pharmacist? Yeah, the you guys will have. This is the model that you'll be familiar with probably, where there is an arrangement for partial funding for pharmacists to be attached to general practice, and you get 60% of the cost in the first year, 40% in the second year, 20% in the third year. We've got a couple of wave 1s, and we are putting together an integrated plan through our GP provider company to submit a bid so that we can get a chance of getting some of the wave 2. If you're interested, the closing date is the 10th of February if you want to be in the first tranche to be considered. We've had some interesting results from this, and certainly talking to our colleagues in the LPC who have some experience through the local pharmaceutical network about this sort of work. Pharmacists are quite expensive professionals, they're not cheap, and using them for medicines management isn't necessarily cost effective. What is really helpful is if you get a pharmacist into the practice to begin with, a good way of orienting them, getting them used to the way of working in general practice, is to get them to review what you do with medicines management, your prescription systems, and those sorts of things. But ultimately, you need those people to be at the front end, seeing patients who would otherwise be seeing a GP. And that's perfectly possible. Ideally, what you're looking for is a prescribing pharmacist. But they can be very, very good at long-term condition management, particularly for those patients who take a large number of medications, heart failure patients, COPD. So it's exciting and there are real benefits, but you need to focus your pharmacists on providing the services that you need, so that by the end of that 3-year run-in period, that pharmacist is replacing a significant number of GP hours you'd otherwise need. We've been fairly keen on triage and signposting. Telephone work is quite big in Somerset, with populations living over many square miles. People don't necessarily want to come trundling through the mud to come see their GP. and independent-minded country people are very happy very often to take telephone advice. There is now good evidence about the effectiveness of diverting patients away from GP face-to-face consultations. If you're thinking about going down this line, then GP Access, the commercial company run by Harry Longman, you may have come across his name, provides a very good model. I've got no shares in this company, I just think he does it particularly well. You need to have a structured plan for doing it. The idea that you can simply say, well, we're just going to talk to everybody on the telephone before we invite them to come and see us, simply doesn't work. You've got to be organised about doing it. And the key here is to have enough capacity so that when the patient rings in, they need to see somebody face to face. You can divert them to the right person, rather than having to say, oh, there isn't anybody else got to come and see me and I've just wasted 5 minutes talking to you on the phone. And one of the interesting things is that when the patient rings in and says, I want to see the doctor, the receptionist can say, can you give me any idea what the problem is? And the patient will usually say, well, I've got this sore knee, whatever it may be. The receptionist can say, well, I can give you a telephone appointment to see the doctor and he will ring you back between such and such a time. Or if you think it's appropriate, I can give you an appointment to see the emergency care nurse. And quite a number of patients will choose to see the nurse, quite a number of patients will choose to talk to a doctor, but you're giving them alternatives, which means the patients are much more likely to be satisfied than if you simply say, no appointments, ring again at 8 o'clock tomorrow morning. One of the other things that we found valuable is to have a really good working relationship with our LPC. Even though most pharmacists are employed by corporates of one sort or another, because Boots and the Co-op, forgot what they call themselves these days, Lewis and the others are the majority contract holders, certainly in the West Country, but relatively few independent pharmacists left. The pharmacists working with them are still autonomous professionals, despite being employees, and they're very interested in working collaboratively with general practices. And we had a bit of a problem at the beginning of the season when the flu vaccines were delivered earlier to pharmacy than to general practice. Did you have this problem? Yeah, I think most people did. And that caused all kinds of ructions and a certain amount of catfighting down at practice and pharmacy level. That we and our LPC colleagues had to soothe quite a lot of ruffled feathers. And falling out of that was a conversation we had at our local flu group saying, well, this is a nonsense really. Across the NHS, we're trying to be collaborative. We're setting up, the department has decided to set up a commercial, competitive model for this service. Is that the best way forward? And we thought it probably wasn't. So what we said, well, why don't we try and come up with something collaborative? And the model that the LPC general manager and I drew up on the back of an envelope was that if we took a cohort of patients, let's say the at-risk adults, and we said that if you could increase coverage by 1%, that would be the threshold to attract an incremental bonus. And for every percentage point above that, you could earn a certain amount up to a maximum of, say, £3. Of that £3, something like £2 would go to the practice and £1 would go to the pharmacy. And that would be on top of the immunisation fee. Now, that may not seem very much, and it may not seem very attractive, and there are clearly flaws with that model. But what is interesting is that people were really quite enthusiastic about this idea. People want to work collaboratively, both in practices and pharmacies. Nobody's very comfortable down in primary care, certainly in our neck of the woods, in feeling that you're competing with folk that really rely on you and you rely on them for the provision of a safe service. So we've still got a little way to go, but NHS England locally is certainly prepared to talk to us, and we're hoping to run at least a pilot of that next year. So working with your other local representative committees can be really quite fruitful. Right, here's the big one. 7-day access in the Tory manifesto, 2015, constantly repeated by senior politicians ever since. Whatever the politics of it, this is coming our way like an express train. Well, we thought we were safe because this wasn't going to happen until 2019, but the CCG rang up in October and said, no, you're not going to like this, but we've been selected by NHS England as an early adopter site, and they want us to have something running in 4 months' time. Oh, we said. Then we went away to look at the specification and the operating framework for 2017 to 19, and it's on one side of A4 in quite large letters, and it contains really very little. And the requirement is for GP services, not GP appointments. It doesn't matter who provides them, and it doesn't matter how they're delivered. They don't have to be face-to-face necessarily. There's a substantial amount of extra money that's available to the CCG for organising this. In our case, it's something over £3 million. And practices aren't required to participate. This is an obligation that's placed on the CCG and not on individual practices. There's a requirement for a mixture of pre-bookable and same-day appointments. There's an absolute need for some sort of integrated IT arrangement, which fortunately we should be able to provide. And there's nothing to stop you doing it collaboratively in a cluster or across a hub. So you don't have to have every single practice open 8 to 8. Now, most particularly, the weekend obligation is left very open. Weekend opening is according to locally determined need, unquote. And the evidence that we have, which is the same as that across much of the country, is that there's quite a lot of interest in having access to GP services in some form on Saturday morning, less on Saturday afternoon, and very little on Sundays. People don't really want to go to the doctor on Sundays. So, this is what we were presented with. All sorts of questions flow from that. How does it relate to the out-of-hours service? What about walk-in centres, minor injury units, all the other providers of out-of-hours care? Is this out-of-hours? Is this extended hours in a different form? What's different about it? And the answer came back, well, NHS England is not imposing any rules. We can be very flexible within the broad terms that have been laid out. So we went away to think about it, and actually somebody at the CCG came back saying, why don't we take the current extended hours, sorry, mislabelled it there, the extended hours enhanced service, which most of our practices are providing, revamp it so that it meets the terms of the approved access requirement, and go back and ask NHS England what they think. And the answer came back from NHS England, well, we think that probably would work. So the plan we're currently working on is to adapt to the existing enhanced access, extended access enhanced service to meet the new requirements. And the new requirements for patients to have access to services every evening from 6:30 to 8 o'clock, and for a period of time at the weekends. And they must be able to book these appointments either through the practice's normal arrangements or some new arrangements. In other words, they can't be entirely controlled by the practice. Because appointments don't have necessarily to be face-to-face, being able to book on the day may mean that you can book up until 6:30, but at 6:30, as with the extended hours, your phone switches off and you simply see the patients who have pre-booked. At the weekends, on Saturdays, we interpret it as meaning that patients need to be able to book and have access, but that could be by telephone rather than by extra face-to-face appointments. So the key to this, as far as we're concerned, is that it's not extending normal GMS to a further number of hours, evenings and weekends. It is providing a different, much more limited service. So the idea that we're all going to have to provide 8 to 8 services 7 days a week is certainly not what NHS England are asking our CCG to pilot. It's a more modest arrangement, and we think it's probably achievable, even in the current climate where practices are exhausted, GPs are struggling to manage their 5-day commitment. We think this can probably be done. So that's a bit of a romp through some of the things we've been doing at Somerset. What have we learned? Well, this is the most obvious one. People from other parts of the NHS really don't understand what happens in general practice. They don't understand the autonomy of GPs and independent contractor status. They don't understand our very flat management organisations. They don't understand that if partners want to make a decision and paint the waiting room purple, they can do it now. You don't have to ask anybody. You just paint the waiting room or get a painter in to paint the waiting room. And I think they don't understand how very efficient general practice is, because individual GP clinicians and senior nurses are able to deal with patients much, much more quickly than more structured organisations. And the reasons for that will all be familiar, to do with knowledge, experience, being a generalist and risk management. Here's a GP on his mountain bike on the Quantock Hills. What you notice about him is he's on his own. And that's what GPs largely traditionally do, consult on their own. And what we need to do is to build better primary care teams to pull the GP out of the consulting room, carrying all the responsibility, all the consultations. And maybe the best thing that the health coach model is going to offer is the capacity of the GP to have somebody to take on more of the routine things than making of the telephone calls and all the stuff that at the moment generally the doctors are doing for themselves. So, the principles of what we've done and what we've learned from other parts of the country are transferable. For example, GPs don't have to do their own home visits. Somebody else can do it, and that's perfectly safe and acceptable. What may not be transferable is the model. So the idea that you could go on to somebody's website and say, oh, this fantastic group of practices provides this service in this way, and that's the answer, it probably isn't. You take the principles and you say, how could we make that work for our health configuration? This is a lighthouse. This is the Somerset version of a lighthouse. Now, lighthouses are normally stone things built on rocks, and they're round with a light on top. Our lighthouses are different. First of all, this is in the Bristol Channel, and it's mostly on the leeward side of the land, so you don't have raging storms, so you don't need a big stone structure. It's not built of heavy stones because the ground is very, very soft, sandy and muddy. So you make it light, make it out of wood, and you put it on lots of stilts. It's not very high up because the river traffic isn't going to be very far away. They simply need to be able to see you in the fog, so they don't drive themselves onto sandbags. So this is a lighthouse. It looks totally unlike most people's image of a lighthouse, but it does the same job. It keeps vessels off dangerous shores. And the same sort of principle will apply. Your service configuration may look totally different to the standard model, but it'll do the same job. Clearly, when you're working with other people, they're going to come with a different culture. And we know that ambulance trusts, secondary care providers, mental health services have a different culture. And we're gradually learning to assimilate that and understand it. The difference between healthcare and social care is a wider gap. You know, the joke always goes, how long is an emergency in A&E? 30 seconds. How long is an emergency in general practice? 2 hours. How long is an emergency in social care? A couple of weeks. There are differences in the way in which we view the world, and you need to be able to integrate those and have time to do it. And in a modern world, you can't change things by bootstrapping the whole exercise on your own. If we had 37.5-hour working weeks and GPs were spending their time sitting around wondering what to do next, yes, of course, you could drive a lot of these things. But to make the sort of complex changes that are required at the rate that they need to be made, you need to bring in somebody with the right skills and expertise. If you're going to make a change that's going to make a difference, you've got to have enough of a change If you bring in one session of pharmacist time a week, you're probably not going to make a lot of difference to the lives of the frontline GPs. If you bring in 3 full-time paramedics doing all the visiting, you're making a big difference. So there is a critical mass at which point something really becomes effective. Here's a picture. I don't really know where it is. This is a trick question. It's not Glastonbury at all. It's a place called Barrow Mump. It looks a lot like Glastonbury Tor. It's just up the road. It's slightly lower, and the ancient building is slightly more crumbled down, but the grass and the cows are much the same. And the point about that is that it may not be recognisably the same place, but it is recognisably doing the same thing. What you need are clinical decision makers who are going to take a load off a GP. You need people who are able to deal with some of that generalised work out there, who are able to make autonomous decisions, who are not constantly going to be knocking on the surgery door saying, I've seen the patient, what shall I do next? But those are expensive and they may be difficult to find. So the other idea is to go to the bottom end of the demand pile and look at those patients whose needs can be met by somebody who doesn't have to be a clinical decision maker. And that's why we feel that health coaches can be very effective with some of those patients who use more services than others. This one's self-evident, really. These processes need to be evolutionary. It's very difficult to go from where we are now to a fully formed, perfect model of a way a service is going to work. It's sometimes easy to be paralysed by the need to just sit there and work it out, work it out, work it out, work it out, to the satisfaction of all the managers who are involved, that you've dotted every I and crossed every T. Sometimes you just have to go away and do it in that traditional GP fashion. So we're going to give it a go. And so long as you know that you're doing it in a quick and dirty way, the outcome may well be achieved more quickly if you're prepared to adapt and evolve as you go along. This is fairly obvious. Choose a small problem. Don't say, we are going to redesign the entire way in which our patients access GP services in this locality. It's a great project, but it's a big one. And if you're trying to do this from a practice level, or even a locality level, go for something that's more achievable. This is a Glastonbury Festival. It's the universal cry is there are no appointments. So whatever we do, that's what we're trying to do something about. And the final message is that general practice partnerships still work for the reasons that I've touched on. It is a very efficient way of delivering services. It may be a bad system in many ways, but as Churchill would have said, if we paraphrase, it is the least bad of the options, or rather, it is less worse than the other alternatives. So the partnership model is still good, it's still efficient, and it can still be profitable. And I think, as colleagues have described, running a practice using entirely salaried and employed staff is not so easy. And this one's obvious, really. We know the pace of change is constant and inexorable. We think we know what the government thinks it might want at the moment, I think. What we don't know is what they're going to need next year. We certainly don't know what they're going to need in 2 years' time. And we have absolutely no clue what a subsequent government's going to want. So you'll need to be thinking about future-proofing and keeping anchored in a service delivery model that works rather than floating too freely off into the future. And you may not be able to see this, but this is something called Harry's Cider. And it's brewed in Long Sutton in Somerset, and it happens to be my favourite, not just because it shares my name. So there are many good reasons for living in Somerset, and this is my favourite.
Thanks very much, Harry. So again, we've got Harry's come a long way to come and talk to us. So any questions about Harry's experiences in Somerset or the way that the work's being done, or just anything generally? If you'd like to pop your hand up, then we'll give you the mic.
Thank you. Question about the Somerset Symphony. You mentioned on one of the slides, but didn't go into detail in the talk, that there was an element of social care. Could you unpack that a little bit more as to how that's worked with the integration and the resourcing, and whether there's aspirations to do anything different in the light of STPs?
I think it's fair to say that conversation is still taking place for all the reasons that you mentioned. Social care funding is an enormous black hole and shows no signs of getting any better. There is cooperation going on to try and make sure that we use the resources that are across the margin, things that might fall out of the old Better Care Fund, for example. And the Yeovil District Hospital has actually taken some care home beds using its own budget so that it can move some of the detox, the delayed transfer of care patients out of its own beds so they can be held somewhere while social services move things on. And that's been a collaborative activity. So the formal integration of parts of the social services budget hasn't happened, and I think it's going to be very difficult to work how we're going to do it.
First of all, I'd just like to thank you for a fantastic talk, and that was really inspirational, so I really enjoyed that. My question is, it sounds like you, at the stages as you were moving forward in Somerset, you did benefit from some Vanguard funding and some significant investment, and I was just wondering what tips you might have for those of us in other areas who are aspiring to perhaps do similar things, but don't have the benefit of those funds. Do you have any tips, just in terms of how we might manage that?
Yeah, some of our best projects haven't been funded at all, like the paramedic one. And the ones that work on that basis, you start with a group of practices identifying a need, and you use your local resources to make a small step towards where you want to go. Now, I think when they came to employing paramedics, the opportunity was there. There was somebody who knew that paramedics might be available. They identified some resource to be able to pay for them, because I think both practices, the key practices involved, were currently recruiting. So they said, well, we could save some of the budget that's been released by not having a GP partner. But it's absolutely right that if you want to do something big, you probably need the backup funding. Some things you can mirror from what's gone elsewhere. So the original Vanguard work was done down in South Somerset, and we've got two other localities in Mendip and in Taunton who basically picked up that work and are replicating it stage by stage, not in exactly the same way, and they've had much less funding. And it works because the demographics and the structures are sufficiently similar between the three localities to be able to adopt their model. But start small, don't be too ambitious, but find something that all of the parties agree is achievable.
I've got a question. You talk about your GP provider. Sorry, over here. Thank you. You talk about having a GP provider arm as well. Perhaps you could tell us a little bit more about that as well and how that functioned.
Yes, we set up a company called Somerset Primary Healthcare Limited. Each of the practices in the county is a shareholder. It has a fairly complex structure because there are A shares, which are the voting shares, and each practice has one, and there are B shares, which are proportionate to the size of the practice based on patient numbers, and therefore the financial involvement of that individual practice in the company. It was originally set up with a view to bidding for contracts that we thought we might lose when competitive tendering came in, and it did bid for a couple, but they are contracts that have rather petered out for one reason or another. So we don't feel that was a great loss. And the company's been refocused recently to providing support for practices and in working to help with integration and sustainability. So that's its primary function. It's also able to hold contracts, it's got all the necessary formal structures, it's got an M3 connection, it's got information governance approval. So it's able to act as a provider in its own right, or simply as the business manager, the partner for other locality providers in smaller parts of the county.
I'll save Amanda from running up here and I'll give you the microphone back actually, Harry. So there were some questions just based on the presentations we had earlier from Chand, and we talked a lot about the MCP model. I just wondered if you had thoughts about how you see life going in that way, the potential changes in terms of the current GP contract, and any advice that you might have based on local experience.
Yeah, and the Symphony project is a PAX model. The difference between PAX and MCP is perhaps less than we thought. There is no enthusiasm in our neck of the woods to set up a new MCP, partly because, being so scattered, we don't really have another focus large enough to start an MCP in its own right, and partly because we see that the county is moving gradually towards what used to be called an accountable care organisation, now sometimes called an accountable provider system, and that we don't necessarily see that having an MCP model in there is going to make a lot of difference for us. And clearly there are attractions to it, but it may be an intermediate tier that has a relatively short half-life in our health economy. So for us, it doesn't look like it's going to be something we're going to need.
And also, well, unless there's any other questions in the audience, and just stand up so I can see, has anyone got any more questions? I suppose the other one is really about the independent contractor model, so that's something that is exercised in our LMC, and we're getting questions about this. Given how hard it is to recruit new partners, seeing a situation where there's a possibility where you've got lots of last man standings. Now, when I went to the Secretary's Conference a few months ago, Tom Black from Northern Ireland GPC said he thought that was the holy grail, the contract. It's not going to change. The government needs GPs as independent contractors. Again, maybe something you've talked about in Somerset.
Yeah, we have. I think it's very interesting looking at the different practices. If you are an urban practice, larger, modern premises, training, with a wide range of partner ages, you're quite attractive to young doctors who want to come to the West Country and want to be partners. If you're a small practice, out in the country, paradoxically dispensing, even though there's an income from that, with a group of partners who are all much of an age, maybe in their 50s, and you're not a training practice, you are going to struggle to recruit. And what we're beginning to find is that the urban practices who are beginning to form clusters, little towns, 40 to 60,000 sort of size, are able to recruit partners in, whereas out in between times in the towns and villages they're not. And we see that increasingly those practices are likely to look for alliances, quite possibly with one of our foundation trusts. So far we've had no commercial interest in anybody taking over our practices, partly because a small practice that's isolated in the middle of the Somerset countryside is not very easy to integrate with a portfolio elsewhere. And although some of the larger practices are talking to their smaller neighbours about mergers and integrations of one kind or another, for the most part we see it evolving into these two models: clusters of collaborating practices in the larger centres, and maybe a network of smaller practices that will gradually become integrated with an NHS provider.
Okay, thanks very much, Harry, and again, we'd like to show our appreciation for your... So we've got a few minutes before we break for coffee. We've got just over 10 minutes, really, and then we're going to go into coffee. Then after coffee at 4 o'clock, we're going to have a question and answer session where we're going to have a panel at the front of the stage here, and our colleagues who've come down from the workshop, so hopefully a good number. We can engage in an interactive discussion, really, about anything that you want. So it's really about the audience putting in issues or questions for the panel, who are commissioners and provider GPs, to answer. And again, it's really, hopefully it's going to be interactive and something that you get a lot out of, because we don't get the chance to do that very often. You have a lot of discussions with commissioners in your own areas, but to actually get a sample across the areas, across Notts, is quite rare, and I think it's a good opportunity for us. What I'd like to do now, though, just for the next 10 minutes or so, is I'm going to invite a couple of colleagues up. So I'm going to invite Colin up from BHP. I'm going to invite John Crafts, who's on his way down as well, who's been doing the HR workshops. Kieran Sharrock may be able to join us as well, who's doing some salaried sessional work. But just for 10 minutes or so at the front of the stage, again, just to take some themes from what came out in the workshops earlier, and the guys could tell you what they covered. But also, if you've got any questions that you haven't had a chance to ask, because perhaps you've been in here and you couldn't go to that workshop, or you have something that's come to your mind in the last 5 or 10 minutes, then it's a great opportunity before coffee, just for a quick question and answer session with some of our experts. So we're going to have some of the guys coming to join us, but Colin, I'm going to bring you up a chair for the front. So hopefully, you might have stored them up, but if you've got any questions about finance and soon about HR, then we'll try and get them addressed for you. A lot of the issues we just discussed in the last few hours around the collaborative working brings up a lot of finance issues and costs, which were covered partly with IMH earlier, but also HR, which is why when John comes, I think it's going to be really useful as well. And then perhaps Kieran can tell us what the latest score is really for sessional GPs. Earlier on what was said was that sessional GPs makes up very close to around 50% of the GP workforce, which is quite a stunning amount really when you think about it. We used to think it was about the partnership model, and then some sessional GPs coming as well. The balance is changing very much. So Kieran can hopefully talk to us about his experiences in the subcommittee of the GPC. John, we're going to bring John up as well.
Thank you very much.
So, up on the stage, please, John.
Thank you very much. Bless you.
So what we'd like to do is, as I said, it's quite a rare opportunity again, away from the workshops. Some people may not have had the chance to ask questions about finance, about HR, employment law, etc. Just gives you a chance to have any free questions for the next 10 minutes or so before we break for coffee. What we'll do afterwards at 4 is we'll have our Q&A across the board, and then we'll do the prize draw, which you should stick around for, because it's some good John and Lewis vouchers, £100, £50 and £25. But then we'll also, to close the session, to close the day, we'll also have a special message that we've had recorded for us, and we're looking forward to showing you that one. So it's very kind of to do that. So, we're bringing Kieran up as well, and anything at all on sessional. Yeah, do you want to come, Mick? Mick's great, Brian Jacobson, great on the premises issues as well. So anything on finances, premises, sessional GPs, HR, employment law. A big kind of range of advice now that we've got for the next 10 minutes. If anybody wants to avail themselves of it for free, they're here. Let's use it. So any questions to our panel on any of your practice matters? Oh, Sonali at the back.
Yeah. You've got to have one person on the prime to ask. That's right. Yeah, that's right. Yeah.
Sorry, I don't know if it's already been discussed. So it's Sonali Kimra, one of the GPs from Nottingham City GP Alliance. We're looking at the clinical pharmacist pilot scheme, and of course it talks about one pharmacist covering about 30,000 population. So just wanted to know what about your views as to we're going to be talking about sharing employees here across many different practices. There's possibility also sharing it across secondary care. And when we're going out to set up contracts, how do we really do these contracts may be different from your standard contracts which you're holding in your each practice. So how do we go and do that negotiation with each practice to say it's better to have a standardized contract across maybe 10 practices who are going to be employing these 10 different pharmacists, or maybe 30 practices that are going to be employing 10 pharmacists?
I think it's, yeah.
Hello, Sonali. So we're talking here about money coming into an organisation to enable you to deliver services across a range of practices. So we need to understand, first of all, how we share that risk amongst the organisations that are partnering in that arrangement. We need to understand who is the lead employer for the purposes of this arrangement. Is that going to be a practice within the federation, or is it going to be the federation itself that's going to be the employer? After that, we need to understand precisely what risks are associated with that. Whenever I'm advising on this, I always say it's great to be a client practice, so in other words, I'm receiving services from somebody, but I'm not actually accepting the responsibility of being the employer. So we need to understand in those circumstances what are the responsibilities of the lead employer, whether that's a lead practice or whether it be the federation, and what are the responsibilities of the client practices. How do they work together to manage things like personal development, annual leave requests, how do they manage discipline, how do they manage incapability, what happens when it all goes wrong and the employee leaves and claims a constructive dismissal, what happens when the clinical pharmacist makes a complaint to the lead employer about the conduct of one of the practices or the practice manager, all of this sort of stuff. It all sounds like it's a lot to deal with, and it is a lot to deal with, but many of the problems will be minimised if you plan for them and stick it all down in a risk-sharing agreement. Some time ago, Gately's, sorry to say Gately's, I did work with Gately's on a risk-sharing agreement to enable everybody to understand what their responsibilities are in these circumstances and how the risks are shared. So let's get people around the table and let's get them talking about risks, responsibilities, and let's get them to sign up in accordance with that agreement.
Andy at the back.
Can I just mention a tax point there, because if one practice employs all the employees and then they're recharged across to other practices, that can create VAT issues. So you do need to be careful of VAT if you go down that route.
Andy Foster here, also working with Nottinghamshire General Practice Alliance. Got a question about 2P. We're often sort of engaged in the exercise of going out and looking for services that we might provide on behalf of practices. And a lot of these services are previously or are currently being provided by other providers in the city. So the transfer of those services might involve a transfer of staff in some way. There might not be all the same staff delivering that service from another provider, but some of them, and they might be employed by not just one organisation, but lots of different individual practices subcontracted to provide them. And sometimes those organisations who hold the current contract sometimes just drop in, oh, but you've got to think about the 2P liabilities, and I never know quite what to make of that. Just really, how big a problem is that? Would that apply in the situation that I described, or should we be factoring this in or afraid of this as a consideration?
Potentially it's a massive problem, particularly if you are potentially receiving staff from an organisation which has a history of employing people under NHS terms and conditions. I think we know who we're talking about. So you may cop for a number of staff that are employed on agenda for change, that recognise trade unions and so on and so forth. So potentially you will be accepting the employment of those people because you are picking up the service. The other thing you said, Andy, was that it's very different circumstances depending on which transaction you're thinking about. There may be staff employed by a number of people at the moment that are coming together to provide the services in future. So there may be all sorts of things that are happening in the course of the change of contract that mean that 2P doesn't apply. It's never open and closed whether 2P applies. We always have to look at the individual circumstances associated with that. But 2P certainly does apply to contract service changes, the sort of services that you're talking about. So early on, I think, when you're talking to whoever it is that's commissioning services and potentially changing whose services are delivered by, in terms of you need to start thinking very early about 2P and employment liability.
Thanks. I'm going to be quite cheeky really and put Kieran on the spot, so apologies in advance. Kieran's the medical director of Lincolnshire LMC, as well as on the GPC subcommittee for sessional GPs. But I wonder really, Kieran, if I can just ask you just to take a couple of minutes to tell everybody about the international recruitment, because it's such a jewel in the crown, isn't it? It's something that we're very proud about. Lots to learn from it, lots that we might learn from it in Nottinghamshire, and a really interesting project. And what I'd also say, if you don't mind the panel, before we wrap up after Kieran's answered that, is if you wouldn't mind just maybe one golden tip that you can leave with the audience before they go to coffee, based on maybe the sessions you've had so far, a nice takeaway tip. But while you're thinking about that, I'll just ask Kieran to talk about international recruitment, if you don't mind.
Hi. Yes, so we're recruiting doctors from across Europe to Lincolnshire at the moment because clearly there's a shortage of GPs throughout the whole country. And what we did is we marketed Lincolnshire quite heavily. You probably saw adverts in the BMJ, and we were quite successful. We recruited probably 10 GPs. But the longer the campaign went on, the quieter and quieter it got. We realised we were fishing in a very small pond, which was empty of fish, and we'd hooked all the fish that were likely to get hooked and created a vacuum. And therefore, we weren't going to get any more. Whereas we still have a vacuum of 75 GPs across Lincolnshire, and 75 GPs plan to retire in the next 5 years. So probably potentially 150 GPs short in 5 years' time. So we really started recruiting from across Europe. We went across to Czech Republic, Poland, Spain, all over the place. Anywhere they had GPs, we tried to find people. And there's a number of barriers to recruiting doctors from abroad. I could go on about the bureaucracy and the ridiculous nature of how difficult it is to recruit people. We were going through that process when the GP Forward View came out last year, and in that it said NHS England were going to recruit 500 GPs from Europe. So we knocked on NHS England's door and said, well, we're already doing this, so why don't you help us? And thankfully they said yes, and Health Education England, NHS England and the LMC together have pulled some cash, and we're recruiting 25 GPs. Now, we're doing this with the help of NHS England and Health Education England, because we've promised to then go out to other areas and tell them what we've done, because we've learned so much. There's so many hurdles and barriers that we've had to break through. And what we're doing is we're putting papers together for the next round of people who are recruiting from Teesside to Essex to various other places across the country. And I'm sure it won't be long before Nottinghamshire is also looking for doctors from abroad as well. And we're happy to share our learning with whoever. But we're doing that through the NHS England national team. We've got currently 12 doctors from across Europe training in Poland, improving their language, giving them NHS orientation, so that when they get here in April, they will have high-level English with consultation skills trained to them. And also we're building a learning plan for them with the RCGP, so that when they get here we can give them the right education to make sure that they're GPs fit for the UK. Because general practice in Spain, Italy, Poland is very different from general practice in England. So even though they are GPs, they won't be UK trained GPs. But after 18 months, 3 years with us, they'll have done their vocational training with us and they'll be fully up to speed. We've got them, they'll be arriving in April, and then we've got another 13 being interviewed in a couple of weeks. So hopefully by August we'll have 25 GPs from Europe in Lincolnshire, and we will share the learning we have with that with Nottinghamshire and any other LMC and any other organisation that NHS England directs us to.
Many thanks, Kieran. So that conversation we'll have again about in Nottinghamshire, so that's really interesting. We watch with interest, and I think more time to work together would be great on that. So I have put you on the spot, but if you wouldn't mind just saying a little tip, a little nugget perhaps, that you want to leave behind for everybody in the room before they go to coffee, then that'd be really appreciated.
I'll look first. For the GPs in the room, NHS pension, review your position, change the pension quotes. There are serious tax costs around the corner. We've just had a 38-year-old with a £50,000 tax cost down to her personal circumstances. But for most GPs, you'll be looking at costs of possibly £10,000 to £15,000 on top of your normal tax bill, particularly the more senior ones. So get a pension quote and talk to the pension advisor. For the practice managers in the room, cloud accounting is the way forward. With the HMRC rules coming through, cloud accounting will be essential in 2 years' time. We're actually pushing zero at the moment. That's the product we think is the way to go.
And if you don't mind, I'll give the sessional doctors in the room a tip as well. I don't know how many of you there are, but equally on pensions. The way that pensions are calculated has changed for sessional doctors. And it's something that you need to ask your accountant about, because the annualised earnings have come in So yeah, if you have a friendly accountant, speak to them.
My message is for practice managers and I suppose GPs as well. This year we've been doing a lot of work on contract variation and loving your high performers. Your high performers, whether they be secretaries, salaried GPs, secretaries or whoever they are vital to your business, and you have the power to love those people and make them stay. And you also have the power to get the other people who aren't high performers up to that standard or to consider their futures. That all sounds a bit cut and thrust, but I'm afraid you're living in a cut and thrust world, so you probably think it's necessary.
Okay, so my session was on merging of the practices, particularly premises. So I think the key message would be if you're merging with another practice or you're thinking about practice mergers, make sure you do all of your due diligence and make sure you know exactly what you're signing up to and what you're signing legally, because it's really easy to get caught out later without checking things properly.
So I think I'd like to say a big thank you to the panel who have convened and given some good tips in the time-honoured fashioned way. So we break for coffee now. So again, it's upstairs this time. It's not downstairs. So back upstairs if anybody would like a coffee. And we're looking to reconvene at 4 o'clock. And what I would say is that we're going to have an interesting Q&A session. So have a think about whether you've got any burning issues or questions you'd like to ask the panel. And then after that, we're going to talk a little bit more about the, well, we're going to do a prize draw. And we're going to just talk a little bit more about our special guest who we're going to show you the message from. So if you can stay with us until 5, just after, that would be fantastic. And coffee's up, so please make your way up and we'll see you at 4.
Thank you. How are you? Diamonds, yeah. Met right, met Ben. No, we had a... I think he started I haven't heard any noise from it. It's always a good sign. Yeah. So, we haven't heard stuff. That's normally good.